Good afternoon, and welcome to today's webinar, Mental Health and Substance Abuse Integration, Strategies and Lessons Learned from Around the Nation. I'm Georgia Maharis, Project Director for the Vermont Healthcare Innovation Project, as well as Deputy Director for Healthcare Reform for Payment Delivery System Reform at the Agency of Administration. I'll be moderating this afternoon's webinar. This event is part of the Vermont Healthcare Innovation Project's webinar series, which presents a webinar on a new topic monthly on the second Wednesday. Before we get started, I'd like to go over a few items so you know how to participate in today's event. On the left side of this slide, we've included a screenshot of the webinar's attendee interface, the control panel. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer's speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed. We have a few housekeeping items. We have set aside time for discussion and questions at the end of this webinar. You will have the opportunity to submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. During the Q&A session, we will have a moderated discussion to answer your questions. Today's event is being recorded. The slides and recording will be posted to the VHCIP website, healthcareinnovation.vermont.gov, within the next few days. You will be notified when these materials are available. At the end of today's event, you will be redirected to an evaluation survey. Please complete this survey. We value your feedback. Finally, I want to thank Christy Geiler and Sarah Kinsler for planning this webinar and taking charge of logistics for today. Our presenters today are Allison Hamblin from the Center for Healthcare Strategies and Ginger Cloud from Central Vermont Medical Center. Allison Hamblin is the Vice President for Strategic Planning at CHCS. In this role, she helps guide CHCS's program development and organizational planning activities. Ms. Hamblin also leads CHCS's program activities related to integrating care for Medicaid beneficiaries with complex needs, with major initiatives including the Innovations in Complex Care Program, a national initiative supported by Kaiser Permanente Community Benefit to develop integrated care models for Medicaid's highest need beneficiaries, Transforming Complex Care, which is a multi-site demonstration supported by the Robert Wood Johnson Foundation to advance evidence-based, highly replicable approaches to complex care management, Advancing Trauma-Informed Care, a multi-site demonstration also supported by the Robert Wood Johnson Foundation to promote the implementation of trauma-informed approaches to care, and the New York Health Home Learning Collaborative, a New York State Health Foundation-supported effort designed to promote best practices across the statewide health home program. Ms. Hamblin has previously led CHCS's efforts in developing return on investment tools and assessing business case for quality initiatives. She has specific expertise in the areas of physical and behavioral health integration and complex chronic care management. Prior to joining CHCS, Ms. Hamblin worked at Apex Partners and Goldman Sachs & Company, where she provided venture capital and investment banking services to companies in the healthcare and technology industries. She has a master's degree in public health from the University of North Carolina at Chapel Hill and a bachelor's degree in biology from Duke University. Ginger Cloud is the project manager for implementing the screening, brief intervention, and referral to treatment model, known by the initials SBIRT, throughout Central Vermont Medical Center medical homes. She is dually licensed as a mental health and substance abuse counselor. Ms. Cloud's responsibilities include flow development of SBIRT model integration, taking healthcare professionals, including MDs, PAs, nurse practitioners, RNs, and others in the screening process, brief interventions, and motivational interviewing skills. She's responsible for clinical supervision of behavioral health clinicians, integration of SBIRT data into EMRs, data analysis, fiscal reports, and outreach to statewide stakeholders regarding SBIRT model utilization and effectiveness. We welcome Allison and Ginger, and thank you for joining us today. We'll start today's webinar by hearing from Allison as she describes key national trends and lessons learned in integrating mental health, substance abuse, and physical health services. Ginger will follow with an overview of CVMC's SBIRT program. We will end the hour with some time for Q&A. And now I'll turn it over to Allison.
Great, thank you so much. It's a pleasure to be with you all today, and just want to do a quick check and make sure you can hear me okay.
We can, thank you.
Okay, excellent. Great. Well, we can go to the next slide. Just to tell you a little bit about the Center for Healthcare Strategies, for those of you who may not be familiar with our organization. We're a nonprofit health policy center focused on improving health for low-income Americans. And that generally means that we have a large focus on working with Medicaid stakeholders across the states in a variety of areas. The area that I focus on here and where I lead our team is around integrating services for people with complex needs, so that orangish third of the circle on your screen. So the issues around integration of mental health and substance abuse treatment services are at the forefront of the work that we do here at the center, and it's a real pleasure to be with you today to talk about various ways we're seeing states across the country and Medicaid stakeholders in particular looking to promote integration with the goal of improving health and improving outcomes for vulnerable Americans. Next slide, please. So I want to just start out by speaking of a few of the key drivers of this real accelerated interest that we're seeing across the country in integration activity focused on mental health and substance abuse services. This is not an exhaustive list, but I think these are some of the key motivators or contextual factors that are really accelerating these efforts across the states. Many of these I expect are familiar to you, the first being the Mental Health Parity and Addiction Equity Act, which is more commonly referred to as parity for short, is really creating a culture of expectation that all individuals should have access to mental health and substance use disorder treatment services, and is providing new incentives for states to consider how their delivery systems promote closer integration of these services, particularly given new administrative and regulatory requirements around ensuring parity. The second driver here is listed as the real push around mental health and substance abuse that's come from Medicaid expansion in those states that have opted to expand Medicaid, and particularly around the enhanced requirements for coverage of mental health and substance use disorder services through alternative benefit plans, which are the set of benefits available to the newly eligible population, again, in those states that have opted to expand Medicaid. Again, this has just really increased the amount of light shown on issues related to mental health and substance use. You're also probably aware that there's been a lot of attention to the fact that among newly eligible populations, there are particularly high rates of mental health and substance use disorders. And again, this has just really been one of the factors that's been driving an increased amount of attention at the policy and payer level around how we can most effectively ensure access and appropriate coverage and hopefully integration as well of these services. Third listed here is payment reform. As you know, in Vermont, there's been tremendous activity around redesigning the way that payers provide incentives to providers to deliver outcomes and movement away from paying for volume towards paying for value. And again, this payment reform effort has really been one of the key drivers in elevating the role and focus of mental health and substance use. And I'll talk a little bit more about that as we go through the presentation. But really, focusing on outcomes and focusing on value and forcing a closer look on where that value can be achieved and what's critical to creating value and to driving good outcomes. Many new stakeholders have, I would say, woken up to the fact that mental health and substance use disorder have clear roles to play and must be addressed when we're thinking about driving outcomes. And so again, in terms of contributing to this increased focus on integration, I think payment reform has really been our friend in moving us in this direction. And the last point here is really a preview to the next few slides, where we just have a lot better data these days from states across the country and from delivery systems across the country, really highlighting the prevalence of mental health and substance use disorder among high-cost and high-utilizing populations, which tend to be the focus of conversations as we move payment and so forth. So why don't we flip to the next slide, and I'll just run through some examples of where we're seeing these data really highlighting the importance of focusing on mental health and substance use disorder integration. The first is an example from New Jersey. This is a study by Rutgers looking at low-income populations across the state. And the key number to focus on here is in that left-hand bar. 81% of high-utilizing populations were demonstrated to have a behavioral health condition, and that's more than 3 times the prevalence among the non-high-utilizing population. Interestingly, looking at that purple bar, 44% of this group has a serious mental illness. And these data really speak to policymakers and to providers across the spectrum, really highlighting the need to address these issues in our efforts to improve care, improve cost profiles and utilization, et cetera, for our most costly population. Moving to the next slide, we see that other states have similar data, and I'm just going to point to a couple other examples here. In California, for example, we see similar numbers where 70% of the highest risk Medicaid population, in this case, are demonstrated to have some mental health or substance abuse condition. Here, again, including 45% with a serious mental illness. So again, representing both the broad prevalence of mental health and substance abuse conditions, as well as the, I think for some folks, really surprising degree of prevalence for more serious conditions. On the right side, we show some data from Washington State, and not to sort of overly beat the drum here. The reason I include data from Washington State is to look at the SUD prevalence in particular. So that orangish or yellow bar, depending on how the colors show up on your screen. In Washington State, they are actually able to marry data not only from healthcare claims, which is really the source of the other data sets that I alluded to, but in Washington State, they are able to also marry data from their criminal justice system. So they have Department of Corrections data, they have local arrest data, county detention center data, and by marrying these other data sources, we actually see a much higher prevalence of SUD in Washington State. And I think many of you would look at the earlier numbers and even perhaps this number from Washington and say, oh, well, these only begin to paint the picture of the prevalence of substance use disorder in our population. And I think if you compare the California 10% to the Washington 30%, it's probably not that there's 3 times as many people in Washington State that have substance use disorder, but Washington is able to capture a much broader percentage of that population by using a broader set of data beyond just what we capture in the healthcare system. So I think that's particularly interesting, and I love to show these this slide because I think it's a sort of a call to action for all of us to figure out how we can most effectively collaborate with our other partners to really tell this story in a more complete way or as best we can. So moving on to the next slide. I wanted to, again, just paint a little bit of a data picture here, and I promise this is my last data slide from a strict graphical perspective. But this is a slide that we've been presenting for years. Many people have various versions of this, but I think this shows just a really compelling graphical depiction of the relationship between mental health and substance abuse comorbidity with other medical conditions, and why, again, from a broader healthcare system and value perspective, we really need to be thinking about care in a really integrated way. So this uses the example of a national Medicaid population with diabetes. The relationships here hold true across any common chronic condition, and we've looked at those data. But as you move from left to right in this chart, we overlay at first just a mental health condition. So the second column in the chart, so to speak, or data point in the chart is individuals with diabetes who also have a mental health condition. Moving to the right, we then look at individuals with diabetes who have a substance use disorder condition. And then on the right hand of the chart, it's individuals with co-occurring disorders, so individuals with diabetes as well as both a mental health and substance use disorder condition. And I think what you can clearly see from the chart is that as you successively layer on mental health or SUD comorbidities, there is a very clear impact on overall medical cost and utilization. So on average, for diabetics, the addition of co-occurring mental illness and substance use disorder increases average costs by 3.5 times and hospitalization rates by 4 times. And again, these types of data are probably not surprising to anybody on the phone, but when you put them on a chart like this, it really helps tell the story of why our system needs to be working in a much more integrated and holistic way to deal with mental health and substance use conditions. It's not just a problem that needs to be of concern in one silo or one sector of our overall healthcare system. This is a much broader issue that affects all of the care we deliver to populations, sort of regardless of setting. Next slide. So now I want to talk about the various ways that we are seeing states and their partners move to attempt to integrate care for individuals with, again, both medical needs as well as mental health and or substance use disorder needs. Next slide, please. One way we're seeing this across the state is through managed care. And I just want to quickly mention this because it is a big focus of activity across the states where historically behavioral health services, so mental health and or substance use disorder services, have been carved out or separately financed or really treated separately. And we're seeing a tremendous amount of activity across the states to figure out how to reduce those silos and better integrate care at sort of that system or financing level. Most of the states that are highlighted here as hotspots are moving to some type of more integrated or carved in financing arrangement for physical and behavioral health services, but some are doing some interesting things in other ways. I'll just mention 2 of them. California has recently been implementing a waiver to better organize their substance use disorder delivery system, including what many folks have been interested in as newly available Medicaid funding for residential services as part of the waiver. So a lot of eyes are on California to see how that plays out. And I'll also just mention Colorado here, which I'll talk more about in a moment, but Colorado is not sort of pursuing this through integrated managed care, but is really looking at provider-level payment reform and delivery system reform efforts to promote access to integrated care for the entire Medicaid population. And again, I'll speak more to that in a moment. Next slide. So I want to talk now about various ways that states are using and Medicaid stakeholders across the country are using care coordination efforts to promote integration across the spectrum of individual needs. Next slide, please. One of the ways that we are really seeing concerted effort around promoting and scaling care coordination is through the Section 2703 Medicaid Health Home Authority, which in Vermont exists as a health home model around hub and spokes for opioid use disorder. And there are a couple of other states who have that approach as well. So highlighted in blue are the states that have approved Medicaid health home models. There are 19 states plus the District of Columbia as of this month. And there are many more approved health homes than that because many of the states have multiple models targeted at very specific populations. Moving to the next slide, we present just a breakdown of the focus of those health home models. And again, for those of you who may not be familiar with what health homes are, in a general level, health homes really provide Medicaid with the authority to pay for care coordination. This was the first really scalable way for Medicaid to use its financial resources to actually reimburse for care coordination activities that, as many of you know, can often be difficult to find ways to pay for and to scale and to sustain. And so that really is the key to the health home program. And what you see on this chart is of the states who have taken up this option, there has been a tremendous focus on integration for populations with mental health and or substance use disorder conditions. The green and the red columns here really highlight those states that have chosen to focus their health home models on populations with these conditions as opposed to principally medical comorbidities or medical conditions, which is highlighted on the left. And so you can see that disproportionately, states are really using this opportunity to promote integration and to enable care coordination across domains for individuals with mental health and substance use conditions. Next slide, please. Some of you may be familiar with the national opportunity for states to apply for a demonstration program around certified community behavioral health centers. Vermont is not one of the states that's applying for this, but I mention it only because it's an interesting example of how some states are looking to further build upon, in this case, their health home model to really further drive integrated care delivery models. And so what's highlighted here in blue are the health home states that are focused on mental health and or substance use disorder conditions. And then the stripes are the subset of those that are actually applying for these certified community behavioral health center planning grants as an overlay on their behavioral health home model. And if you go to the next slide, you'll see some of the integration requirements associated with that new certification, again, which would come through this demonstration. And whereas those of you who have followed this may be more familiar with the demonstration as attempting a new payment model for community behavioral health centers, I think what's particularly interesting to us is the opportunity to really promote and further strengthen integrated care delivery through the requirements under this model, which are more stringent than under health home requirements. And so you can see here on the slide an array of care coordination and integration requirements that these certified community behavioral health centers will be required to demonstrate. Okay, I think we can move on to the next slide. The next area of activity to promote integration that I wanted to mention is in the topic of delivery system and payment reform. And we can go to the next slide. Here we present a continuum of value-based payment strategies that is not specific to any individual payer type like Medicaid. This is one way of looking at the progression or the various ways that payers, including Medicaid and Medicare and commercial payers, are really trying to move from, again, kind of volume-based incentives to value-based incentives. And again, as I mentioned at the outset when we were talking about drivers, this movement and the testing and the implementation of these different type of payment models that, again, are moving over time and evolving over time towards paying for value are really one of the key drivers that are enabling greater integration activity on the ground. And so just to give a few examples, moving from left to right on this chart, so even within the context of our fee-for-service payment system, as sort of the status quo, we're seeing activity to recognize that there's an opportunity to enhance access to mental health and substance abuse treatment services by, for example, in New Jersey, increasing rates to make sure there's greater rate adequacy to encourage providers to participate in Medicaid and to make sure that folks have access to care. So again, even under kind of the current payment rubric, we're seeing some real concerted effort at the state level to address incentives to make sure that access is there, and if access is there, how do we make sure it's integrated with other services? Moving on to the performance-based programs to the right, we're seeing some really interesting activity in terms of using incentives to sort of the traditional medical system, for example, to either co-locate or better integrate and partner with the behavioral health system, mental health and substance use treatment providers. One example is in New York under what's known as the DSRIP program, which you may or may not have heard of. That stands for Delivery System Reform Incentive Program. And that's a big part of the New York Medicaid waiver. Under that program, providers can choose basically project areas or topics that they want to work on in the context of integrated networks of providers. And behavioral health integration has been the most popular project area that's been selected by these participating networks of providers across the state. And so through this program, there are a significant amount of new incentives tied to process and outcome measures for these networks of providers to be demonstrating that they are delivering more integrated care to the populations that they serve. Moving to the right, on performance-based contracts, we're seeing a lot of this at the managed care level across the states. So one state that comes to mind is Kansas, who has inserted in their contract language with managed care organizations a significant number of metrics tied to performance on improving behavioral health-related outcomes for the populations that they're serving, and really holding sort of traditional managed care much more accountable for addressing the mental health and substance use treatment needs and related sort of recovery-oriented outcomes for that population that they're serving, and tying real financial incentives to those metrics. And then finally, as we move to the right towards where much of the focus is in Vermont and elsewhere on accountable care models, so shared savings, shared risk, and capitation, we again here are seeing movement from coordinated to co-located to fully integrated care with reimbursement via shared savings and risk, and ultimately global payments, again, really trying to promote more integration at the level of care delivery and the right financial incentives for providers to do so. So moving to the next slide, I wanted to talk a little bit about some of the payment models currently in use, particularly around care coordination and ways of promoting integration, and just highlight some of what we know works well with them and some of the limitations associated with these different payment models. And I think, what I'd say overall is that we're still striving to get it right in terms of what the right payment model is for any particular state or system or population or program. So the three things that I'm going to talk to you about on the next slide are what works well and doesn't work well around sort of paying specifically for care coordination, around using shared savings and shared risk to promote care coordination and integration, and then third, around global payments. So why don't we move to the next slide, and I'll lay those comparisons out for you. So first, in the blue row at the top of the graph, we see care management per member per month payment. This is what's most commonly used in health home models, and this is sort of straightforward paying for care coordination and providing incentives for care coordination. The best thing about these approaches in terms of, again, promoting integration of care and promoting care coordination is that you're actually directly resourcing that activity. You are directly funding the services critical to preventing avoidable utilization and paying for the consultations for providers to talk to one another and to do case conferencing and so forth. And you really can effectively cover the staffing costs and the infrastructure costs in order to give providers the resources they need to deliver that model. The challenges of care coordination payments is that inherently it's just another fee-for-service payment stream when healthcare is generally moving away from fee-for-service payments. And oftentimes what's most challenging, or one of the most challenging elements about a care coordination program, is actually engaging and finding the folks, the population who could most benefit from those activities, because many folks are not currently engaged in services who need to be, and so forth. And so many states who have care coordination payment models are really still experimenting with the best ways to provide the right incentives for providers to make sure they're going out and finding those populations who can most benefit from the services. And there's also a bit of a balance with sort of how prescriptive the requirements around care coordination programs need to be. And Health Homes is a great example of a program that tends to have pretty prescriptive requirements both from a federal and a state perspective, which may not be desirable. You may want to be promoting kind of more organic development of models that make sense in local communities. Moving below to shared savings and risk. The best part about this payment approach in terms of promoting coordinated care is that you really are aligning incentives, again, from a payer perspective with desired efforts to reduce avoidable utilization and to lower costs over time. You're giving much more flexibility to the providers to kind of do those activities that are going to generate savings opportunities down the road, and you're not being quite so prescriptive about what it takes to get paid. But the downside is these models don't necessarily cover the upfront staff or investments that are needed to really build these models. It doesn't necessarily make them targeted to the populations that could most benefit from these services. And you really need to make sure that there are targeted metrics in place to make sure that the quality of care that you're looking for is delivered. And just because you're producing savings doesn't necessarily mean that the savings are coming from the right places. And so this really needs to be done hand in hand with a really targeted quality strategy. The last thing I'll mention is on global payment, and global payment is sort of where the world is headed, and it could have the benefits of both providing upfront resources through a global payment mechanism to make sure that the resources are there to fund all of the activities that an integrated delivery system thinks are warranted or necessary and evidence-based to deliver desired outcomes. There's a tremendous amount of flexibility in a global payment model, which again I think is why so many folks are headed in this direction. The downside of global payment is it requires significant infrastructure and financial reserves, and probably is only feasible for well-resourced, typically large networks of providers and well-organized systems, given the sophistication required. And again, it really requires that we have a real quality strategy and oversight to make sure that the outcomes that we're all looking for are delivered. So just moving on, I have just a couple more points that I want to hit before turning it back over. One is to just quickly give an example of the efforts in Colorado that I alluded to earlier. So Colorado, under its State Innovation Model Award, has really been focused on integrated care and has been using this initiative under SIM and the resources under SIM to develop a really comprehensive and robust strategy that aims to provide access to 80% of Coloradans across the state in integrated delivery settings. It's doing this through a four-pronged strategy that's focused on payment reform, practice transformation, population health, and HIT investments. And if we go to the next slide, I'll give just a few more specifics in terms of how the state has been looking to really drive behavioral health integration. The goal is to have 400 primary care settings in 4 years that are capable of delivering integrated physical and mental health and I think in some cases substance use treatment. And to do that, the state has really buckled down on the practice transformation support. So it has made small grants to providers through the SIM Practice Transformation Fund. And practice is participating in the first cohort of practice transformation are eligible to apply for up to $40,000 in support over the course of their participation to really support these transformation activities. The funds support training and onboarding of clinical staff, technology upgrades, efforts to promote patient and family engagement, as well as efforts to better coordinate referrals with specialty care. There is a complementary but smaller effort focused on community mental health providers. So these are called the bidirectional health homes, where the state is trying to, again, bring some of this transformation support to the community mental health system as well. And over time, from a payment perspective, the payment model is moving from, at first, kind of if you think of that continuum, paying for care coordination, but evolving over a timeline to shared savings and risk, and ultimately to fully capitated payments. And so I think Colorado provides a really nice example of both real on-the-ground practice transformation support and a recognition of the need to really reform the delivery system itself, and also dovetailing that with revisions to how care is paid for, recognizing that the two go hand in hand. So I'm just going to pause and do a time check. I have two other areas of examples where I'd be happy to speak of, but I know I've gone a little long, so I'm happy to turn it over to the next speaker and come back to this stuff at the end, or keep going. So why don't I just pause and ask that question?
Thank you, Allison. I think what we would like to do is pause for now, turn it over to Ginger, and then come back to you at the end. I think that makes the most sense. We really appreciate it. So we will now turn over to Ginger to provide an overview of Central Vermont Medical Center's Espert Medical Home Project. And just a quick reminder that if you have any questions, please pop them into that chat box on your screen, and we are happy to take them at the end of the presentation. Now we'll turn it over to you, Ginger. Thank you.
Great. Thank you so much. It's an honor to be here today presenting on the work that CVMC has been doing with the Espert project. Next slide. So over the past 3 years, Central Vermont Medical Center has been awarded 2 Espert grants. There's a larger federal grant, which is the SAMHSA grant that Vermont received, which is a 5-year grant. And then our emergency department, after being incorporated into that larger SAMHSA grant, understood that we'd like to try and outreach the Espert program to the medical homes. So we applied for a SIM grant to be able to provide the Espert model services in the medical homes at Central Vermont Medical Center. And so we received that grant as well, and that's mostly what I'm presenting on. And I wanted to touch on both grants because we've been working as a larger team in a lot of ways with coordination of care and being able to identify service gaps. So currently, we are having the Espert model in 6 different medical homes, and we also are in the women's health clinic as well as the emergency department, and we're also on the inpatient hospitalist floor. So we've been able to provide a very comprehensive circle of treatment. When someone comes into the emergency department, they might get admitted to the hospitalist floor, and then they are returned back to their medical home. So that's really nice. And then we're also catching patients that come through for women's health services that may not actually be incorporated into our primary care practices. Can I go back one slide? Great, thanks. I just want to make sure I covered everything on there. Yeah, so I think I did. We can go forward again. Thanks. So one part of the medical home grant, the SIM grant, we incorporated tobacco cessation counseling in that grant, and we also included the ability to offer a certain amount of free nicotine replacement therapy as well for patients looking to quit tobacco use that may not already have access through insurance to nicotine replacement therapies. That's been a huge part of our grant, and I think we've really been able to connect with a lot of people that generally wouldn't come into counseling and actually are having pretty high levels of distress in their life. And so we've been able to capture that population through offering the tobacco cessation counseling, the individual therapy, and we've also been able to then often connect over to maybe a drinking or a substance use problem that they have going on in their life as we've built that therapeutic alliance. So through the SIM grant, we've been able to offer treatment, again, for free at the patient's medical home with the ability to either intervene during a medical appointment or pretty immediately contact the patient through a referral that's come through the primary care provider to set up an appointment generally later that week or potentially even that day, depending on the timing of the referral. And we know that one huge barrier that comes into play for patients seeking whether it's substance abuse services or mental health is cost. And when we think of cost, we're not just thinking of financial costs, but it's financial, it's time, it's the burden of scheduling the appointment, getting the resources to get there, entering a new facility. All these things wrap up to really create larger barriers to access care. And so by having these services directly in the medical home, we really have been reducing some of those traditional barriers associated with seeking treatment. Another thing that we've been doing more recently through the help of Blue Cross Blue Shield is to incorporate the feedback-informed treatment fit tools to help measure patients' level of functioning at each session. So really using evidence-based practice per session versus an evidence-based treatment modality. We certainly do that as well. We mainly focus on motivational enhancement therapy and cognitive behavioral therapy, and then to supplement with an actual taking perspective of how things are going each session has been very helpful. So looking at those important life areas, and then also the perceived therapeutic alliance for each session, because we know that the therapeutic alliance has a great impact on outcomes that help improve effectiveness of psychotherapy. Next slide. So definitely throughout this work of looking to implement the SBIRT model into our medical homes, we've been able to identify several barriers. And these are really the internal barriers, what I like to think of as the medical culture dynamics. So currently, providers are under increased pressure to do many screenings for patient visits in a very small window of time. And so this is an increased burden on providers, also on nurses, on the real system at work in the medical culture, and also on the patient to be able to come in for a specific reason, and then they're screened for multiple other potential complications, and then being able to address all these results that come up with the different screenings that are happening, whether it's through meaningful use or SBIRT or other screenings that are being proposed as new initiatives. So that's definitely a stress on the system. Varied documentation standards. We found this a lot with just looking at reimbursement rates and how to approach SBIRT as far as if we do billing and reimbursement. There's, depending on the insurer type, there are different requirements for documentation to get those codes reimbursed. We also, EMR complications, so making sure that the information is getting logged into the EMR and then being able to access that data. And then again, with the coding structures are very complex, whether it's an incident to billing, whether it needs a modifier. There's a lot of ins and outs when you're going in to a visit that's already going on with the primary care provider and adding additional services. Another thing that's come up that is definitely not new is bias or stigma towards substance abuse population. And as we're looking to integrate care and really join mental health or substance use providers in a medical setting, there's definitely an interface of language and stigma that comes up that can for sure be a barrier, and then also a nice opportunity for training on how to decrease discrimination and stigmas associated with seeking treatment. I think one thing we're also seeing in conjunction with the first point I made around the increased demands for shorter visit types is a high level of provider burnout. And also we have a large amount of providers here at CVMC that are continually retiring. And so these two issues definitely impact the ability to get into a medical home, to integrate a new system of flow and incorporate new skills with the workforce that's already there, given their high demand and workload already existing. Additionally, there's a continual cycling of grants, initiative, and short-funded projects and programs that come through the medical home, are here for a certain amount of time, and then funding doesn't continue for one reason or another, and then that potentially dissipates. So I think there's some stress associated with bringing in new programs because there's so many things that come through and dissipate. And then, of course, there's a shortage of quality trained substance abuse counselors. This isn't new for Vermont, and it's definitely something that we have run into, especially in a more rural area like central Vermont, is just having people in the workforce available to apply for positions and be here. So that's an issue. Next slide, please. And then we have external barriers. So we have struggling system of care for people with substance abuse issues. In our area in Washington County, we do not have a local detox. We do not have a residential facility in Washington County. And we have an intensive outpatient services, and those services are really specifically focused on group, which a lot of people might prefer a different service avenue. So that's been something that has stood out. Also, the statewide, there seems to be an overload for a substance abuse counselor in residential and intensive outpatient treatment centers with their workload and being underpaid, and so definitely contributes to high turnover and inconsistent care. We've also been treating substance abuse problems as a very short-term treatment modality, so very brief treatment. So someone might go to a detox for 5 days, residential 1 to 3 weeks, intensive outpatient, maybe 8 to 16 weeks, and these are all done often at different facilities. So there's a lot of loss that happens when someone transitions care, and then when they come out of those shorter-term bursts of intensive treatments, then back to the medical home, what happens then in the coordination of care there has been inconsistent as well. And then, of course, there's other issues related to releases, complex patient issues, lack of communication, and a real struggle to communicate between organizations as well. Next slide, please. So we've been working pretty diligently to address a lot of these barriers that have come up. We have all of our expert screening tools in our EMR, so we've been able to track our data quite well, give provider feedback, and also see areas of improvement. Clinicians have been able to be available for brief intervention, so that immediate intervention when they're not engaged in a therapy visit. Certainly something we'd like to be able to increase is the availability to be able to offer the brief interventions. So having maybe people as therapists seeing patients, and then also an opportunity to have someone floating more and be available to get pulled into patient visits. So incorporating mental health substance abuse clinician has also given the opportunity to have greater length conversations with providers and with nurses and medical secretaries about the complications associated with people that struggle with substance abuse issues. We've definitely been vocal about the shortage of substance abuse therapists, and will continue to advocate for some type of, whether it's loan repayment or some type of service that really helps us build a larger workforce for substance abuse counselors in our area. We've also established a regional committee that is a collection of statewide residential and outpatient services, and also community resources to help address some of the barriers and the gaps in treatment that we're seeing. And we meet on a monthly basis, and that's been very helpful around coordinating care and identifying gaps in service. Next slide. And then as far as ESPR at CVMC, between the larger SAMHSA grant and our medical home SIM grant, we've screened nearly 24,000 patients, and we've had more than 1,600 patients that have received a brief intervention around their substance use. We've had around 700 patients engaged with brief treatment with one of our counselors, and about 150 of those patients have been tobacco-specific treatment counseling, and we currently have around 120 patients engaged in brief treatment for either tobacco, alcohol, or drug counseling throughout our practices at CVMC. Just wanted to make a quick note as well on our payer mix. So about 50% of the people that come through and get services, whether it's a brief intervention or engage in our brief treatment services, are made up of commercial payers. And then about 33% have Medicaid, 16% Medicare, and then the remaining 2% is a self-pay. So I just think that's an interesting mix of payers, and really speaks to the large need for these services within the medical home for all people coming to our medical homes. I think that's the end of my slides.
Thank you, Ginger. I think we're going to take a couple of the questions that we received through the chat feature, and then Allison, hopefully loop back to you for a couple more points on the slides that you included that we weren't able to get to. And then just would like to note to folks that, of course, the slides will be available online. And as always, if you have any additional questions after the fact, we're happy to help make sure we get answers to your questions. But the question we just want to check in with both Ginger and Allison, and maybe Ginger, you can go first on this. How does stigma around treatment for these services impact care for people who need those services? In particular, thinking that providers get different types of training to help them deal with the stigma, and despite all of the work being done around the country and in Vermont, there's still a bit of a sense that this is different, and sometimes people get treated not as fairly as one would hope. So Ginger, do you mind addressing that first from your perspective, and then Allison, if you could jump in?
Yeah, certainly. So what that might look like in a practice is a patient might get passed over for a screening because whether maybe the nurse or someone might feel like they know that person, they've been their neighbor, they're not going to change, what's the point? So I think there's a certain amount of judgment that comes in through living in a small community where people might be overlooked or not given the opportunity. That certainly doesn't happen a lot. It does come up, though. So whenever you have a screening that is administered by people as opposed to an automated screen, there can be that selection bias. So I think that's a way. And then also some folks that do come through with recurring substance abuse issues come through a lot, and there's a sense of helplessness and I think sometimes hopelessness throughout the team that they're not going to be able to help. So then there's a sense of giving up on a certain amount of people as well that are very high frequent flyers. So I think those things can come into play pretty strongly.
Thank you, Ginger. Allison, do you have anything to add?
Just a couple of points, and really appreciate Ginger's comments there, and certainly she has a closer on-the-ground perspective than I do. I think the only thing I'd add is that what's exciting to me right now in terms of all the work being done is a real recognition of all of the really hands-on training sort of across silos and domains around understanding the language of mental health and substance use, and really educating the medical community on whether it's like the biological mechanisms of these conditions, of sort of the recovery framework, and really not taking it for granted that folks have received education and really understand the science and the evidence around appropriate treatment and what can occur through appropriate treatment. And so I am sort of encouraged by the recognition of the need to sort of not take those sort of cultural and language differences for granted, and to do some real investment in cross-training and education and sharing language and so forth to sort of reduce the divide between sort of traditionally siloed systems, and to elevate the understanding, again, in this context, particularly within either primary care or other medical settings, around, again, sort of not only the conditions themselves, but evidence-based approaches. And the other thing I'd say is that I think there is an increasing appreciation for the really strong capacity in the mental health and substance abuse treatment system around consumer and family engagement, and whether it's sort of motivational interviewing and so forth. I think there is, I don't want to be overly Pollyanna about it, but I think there is, in many places around the country and in many communities, an increasing recognition of all that the mental health and substance abuse treatment disciplines have to offer the medical discipline in terms of effective strategies for working with complex patients. And so these things won't reduce stigma overnight, and I'm aware that it will be an issue for a long time, but I'm hopeful that we'll see issues of stigma reduce over time given all of the investment and activity that's happening in these areas.
Thank you. Ginger, a quick question for you. You'd mentioned the 1,600 brief interventions and 680 brief treatments. And I know that SBIRT is still pretty young in terms of rollout and evaluation. Do you know when we'll have a good sense of the long-term impact and results of this particular intervention model?
Well, I think SBIRT has been well researched over time. So definitely, there's been a lot of documentation. I think there's over 20 states now that have had SBIRT rolled out and researched. In general, in those larger studies, there's been about a 40% reduction in harmful alcohol use, and then also a 55% reduction in negative consequences associated with use. And the larger SAMHSA grant through Vermont, they've been doing some presentations. Wynn Turner is a great resource for that, and they've had similar results come back from their inquiries on follow-up. Our follow-up data for our medical home project, we're really just getting to some of that. So we do a 6-month and then a year follow-up with our patients that have engaged in treatment. And so we're just starting to get some of that information now that we don't have enough to really make any significant inferences. The model itself, though, has been rigorously tested and applied and been shown to be efficacious in these areas.
Thank you. And so looking at the time, we just have a couple minutes left. And I just want to note that we've sparked a lot of questions and conversation. And so I think we are going to do a little bit of work on our end to collect all of the additional questions that we won't be able to answer, make sure we get answers to them, and distribute that back out to folks. So apologies that there wasn't quite enough time to get to all of the questions. There are many. And thank you in advance, Ginger and Allison, because some of them are pretty specific about picking your brains, and we really appreciate both the national perspective and about how things are going on back here at home. I also want to thank all of you for attending today's webinar. Again, really thanking Allison and Ginger for all of their information. Clearly, this is something that's important to folks, and we may come back to a little more work in this area. Once you leave today's webinar, you'll receive a survey on the presentation, and we would appreciate if you would complete that and provide your feedback. You will also receive a follow-up email within 24 to 48 hours with a link to view a recording of today's webinar. And as I said, we will do our best to get those outstanding questions out to you with answers as soon as possible as well. On behalf of the Vermont Healthcare Innovation Project, I want to thank you for joining us today, and we hope that you have a great rest of your day. Thank you.